Hello and welcome, everyone. My name is Karina Patel. I am a family medicine physician and I practice primary care in Atlanta, Georgia. I also have the privilege of being one of the Capello Fellows at Doctors for America, and I'm so excited to welcome you all to our May Advocacy Grand Rounds event. Before we get started, I want to take a quick minute to invite you all to officially join Doctors for America if you aren't already members, and join the DFA fight to improve healthcare for all. We are a movement of over 40,000 doctors and medical students across the country who have come together since 2009 to ensure that everyone has access to equitable, affordable, high quality healthcare
Quality care.
and the opportunity to lead a healthy life. Becoming a DFA member is easy. You can just go to the link in the chat that to support DFA's work to improve healthcare with incredible programs like this Advocacy Grand Round series. Today, we will be live streaming this presentation to Facebook Live as well as recording, and all materials will be available afterwards. A few quick ground rules for this educational session. We welcome all questions. Just please remember to use the Q&A feature on Zoom to ask your questions. We will address your questions during the second half of our session. And also, please look out for comments in the chat. Our DFA staff will be sharing helpful links throughout the session. And now moving on to our speaker. We are so thrilled to welcome Rob Andrews. Rob Andrews is the Chief Executive Officer of the Health Transformation Alliance, or HTA, an original author of the Affordable Care Act, and a former member of Congress. As CEO of HTA, Andrews oversees the strategic direction of 80 plus leading self-insured employers that have come together in an alliance to do one thing: fix our broken healthcare system. Founded in 2016 by four pioneering employers from American Express, Macy's, Verizon, and Caterpillar, the HTA member companies are committed to improving healthcare quality and affordability for the employees and their families. They are collectively responsible for more than 5 million employees in the United States with an annual healthcare spend of over 30 billion and save members 1 billion annually in healthcare costs. So for today's session, we're just going to start off with kind of a fireside chat and get to hear from Rob's extensive experience. So I'll start with some of our prepared questions. Um, Rob, as one of the original authors of the ACA, I'm sure all of us would love to hear a little bit more insight into what the objectives were when you guys were authoring it and what the motivation and driving force for authoring the ACA was.
Thanks, Karina, for the question and for this opportunity to be with you and your peers. I know that it's been a very long day for everyone on this call, and hopefully this can be a positive ending to that day. When we set out to write the Affordable Care Act, there were about 40 million Americans who did not have any insurance coverage at all for their care. So these are folks who weren't on Medicare, weren't on Medicaid. Many of them worked part-time or full-time, but they worked for an employer who didn't provide health care for them, or they were self-employed and didn't have the money to buy a high expensive premium policy in the marketplace. So the idea was to do three things in the Affordable Care Act. It was to get as many of those 40 million Americans access to affordable insurance coverage. It was to strengthen the rights that existed for consumers under insurance policies. And it was to at least take a step in the right direction of longer term cost control by encouraging better practices and value-based care and better practices. And so, for example, the problem we're out to solve was that there were women working in convenience stores for 40 hours a week, couple of children at home. They made too much money for Medicaid, but not enough to afford insurance. And their employer, which was a small business, couldn't afford to insure them, so did not. That was a person we're trying to help. The other person we're trying to help was that it was a fairly common practice in the insurance industry at that time that if you had a pre-existing condition, if you had had skin cancer, or frankly, if you had had a baby, sometimes that was regarded as a pre-existing condition, that insurance companies would either refuse to cover you at all or raise the premium so high that you couldn't afford them. So we tried to do something about that. And then finally, there was a sense that coverage was unaffordable in part because of cost shifting. That when people showed up at the hospital and had no coverage, we had another federal law called the Hill-Burton law, which is still in effect, that says you had to let them in. You had to take care of them if they showed up in the ER, whether they had coverage or not. That's a good law, in my opinion. But that's what we tried to do, was get coverage for the 40 million who are not insured. That was the objective.
Sure. And now, gosh, I should know this. The ACA was passed into law in what year? Can you remind me?
2010,
2010. So almost,
16 years
yeah,
ago.
16 years ago. 16 years of the ACA. And I mean, a lot of laws have been passed and kind of addressed different parts of it and weakened certain parts of it. So in your eyes, what do you see as the future of the ACA?
Well, I would have had a different answer a year ago. The answer I would have given you a year ago was to try to build on what we had done in order to get more at the cost question and introduce more value-based care to the system. Value-based care, in my mind, means that physicians and other healers are paid on the basis of, did they achieve a good outcome, not how many times did they see the patient or how many scripts did they write or tests did they order. I would give you a different, I'd still believe in that. But since then, in my view, unfortunately, there has been a change in the Affordable Care Act, which has increased the number of uninsured again. And that was the so-called big beautiful bill that did two things. It made the cost of the insurance policies in what are called the exchanges, that again, the markets that exist for people who don't get coverage for their employer, aren't on Medicaid, aren't on Medicare, but buy insurance for themselves on their own. There were significant federal subsidies to help keep the cost of those policies down. The so-called big beautiful bill cut those subsidies by a lot. So the number of people uninsured has jumped. There also have been new requirements put on people getting Medicaid, which are purported to be work requirements. But look, there's a lot of people on Medicaid who cannot work, who are constrained because of a physical illness or other disability. And so those two things have increased the number of uninsured by between 5 and 10 million people. So the first thing that I would say is that we have to fix that and restore those subsidies and get more of those people back covered again. But I think the thing that I'm most proud of about the Affordable Care Act is that people with coverage have rights that they did not have before. Again, pre-existing condition coverage is really important. Probably everyone on this call has had some kind of pre-existing condition. And the fact that it is no longer permitted to charge that patient a higher premium or deny them coverage, I think is a very welcome change. I'm sure there's a lot of people on this call who benefited from the provision, said if you're under 26 years old and you're not yet covered, you can be covered on your parents' policy. Both of my daughters took advantage of that. They're now 32 and 33 and 31, but it was helpful to our family. I'm proud of the fact that we have a change in the law that there is no longer a lifetime or annual policy limit. There would be people who would find out that, God forbid, their child had cancer and the child needed several surgeries and very expensive chemotherapy, and they would exceed $1 million in costs for a year or a lifetime, and the insurance would stop. And you would go to the grocery store and see on the bulletin board an ad for a charity golf tournament or a dinner dance to raise money for some family whose child had run out of coverage. That's no longer the case. So these are what I hope are permanent changes in the law to help make things better.
Yeah, I think I appreciate you kind of highlighting all of those things because I think so often now you hear ACA and Obamacare, and because it's been around for 16 years, your thought goes to the marketplace and like that being the core part of the ACA. Um, but there was a lot of other changes that happened that have really reshaped the reality of how we can practice as physicians and how patients can access care. And do you view those provisions like coverage until tw age 26 under your parents, coverage for pre-existing conditions, and the getting rid of the lifetime caps? Do you think those are here to stay, or do you think they're
They're-
at risk
I
for?
do think they're here to stay because they become a part of American life, and people depend on them now. The part of the job that we didn't do nearly enough on, and if I had it to do over again, we'd spend more time and attention to, is changing the system so that care providers are rewarded on the basis of outcomes. Now, I want to say that the outcome should be clinically defined by competent people. I'm not competent to define an excellent cardiology outcome. Cardiologists are. I think that the outcomes have to be risk adjusted. I think everybody on this call understands that. That if you're working at the poorest hospital in the poorest neighborhood of a city, you should not be judged on the same outcomes as someone working in the richest suburb where everyone's relatively healthy and well insured. You have to risk adjust for those factors. But I do think that that's the basis of what compensation should be based on and payment should be based on. I'm not just saying this because of what you do, Karina, for your job, but I think this would have a huge impact on primary care because excellent primary care leads to better long term results. There's just no doubt about that. So the person who has a relationship with her PCP, gains trust in her PCP, is more likely to diet and exercise and less likely to smoke, is more likely to take her meds and less likely to not go 5 years without a mammogram. And that list that I just recited, the difference between that kind of primary care and the absence of that primary care is the difference between night and day. It's the difference between a vastly expensive person to take care of and an expensive person to take care of, but a lot less. And so if we had a system that said, let's measure how well people manage or prevent type 2 diabetes, primary care doctors would be paid a lot more. And in my view, that's a good thing. You wouldn't be in a position where if you graduated with $500,000 in medical school debt, a lot of people on this call probably in that situation, that you wouldn't be able to afford to do primary care because of the relative discrepancy in wages. So that's a part of this problem that I don't think we did enough to address. And it's what we're trying to address in the Health Transformation Alliance. We're trying to, through our bargaining in the marketplace, representing 80 big employers who spend $45 billion a year in the market. We encourage value-based contracts. We have a primary care network where it's a capitated system where the employer pays about $1,200 a year to a primary care practice. But the practice is not measured by, well, you saw this patient too many times, or you saw them for 25 minutes instead of 8. We're interested in, did you get a better outcome? Did the person manage their diabetes better or avoid it in the first place? Are they on their statins, and is their LDL down? Because those are all things that lead to fewer strokes, fewer heart attacks, healthier people, and a better result. So that's what I wish we had done more of in the Affordable Care.
Yeah, no, and I think kind of shifting gears towards that value-based payment models is a big conversation, not just in primary care, but kind of in all insurance right now.
Yeah.
Um, and you mentioned a word capitated that I remember, and I always like appreciate hearing about capitated models, but I think day-to-day clinicians might forget what that means and what that entails. So can you
Yeah,
explain it
it
a little
means
bit?
that there's a budget that you get for that patient for a year. And again, it may be $1,000, $1,200 for primary care. And that's it. That's what you get. If the patient shows up once and has a physical and she's in great shape and going to win the Boston Marathon next year, you still get $1,200. If she shows up every 4 days because she's got all kind of pain and trouble, then you still get $1,200. So there's an incentive to do the follow-up care and the teaching and the nutrition and the exercise and the smoking cessation. There's an incentive to do those things because there's a budget to take care of that person. Now, the budget I think has to be fairly derived. It's not fair to somebody to say that, um, you know, you're responsible for all their specialty care too for 1,200. That's not going to work. But if you align the incentives in a way that the provider system gets paid more if the person's healthier, and the employer pays less if the person's healthier, because the employer is paying the bills ultimately, and the person pays less because they pay high cost share, everybody wins. And that's the kind of system we think we ought to have. By the way, the other part of that is about 35 cents of every dollar that's spent on healthcare is never touched by a doctor, a nurse, a therapist. It goes to insurance companies, pharmacy benefit managers, money managers in between. And I think another large goal of our system is not to eliminate all those groups in the middle. They serve an important function, but to align what they're paid with the value of what they do. So if a primary care doctor does a terrific job in convincing and persuading a person to diet and exercise and their A1C drops and they feel better and they're all better, and she's getting $130 for the visit, gross for the practice. That doesn't seem right to me when the health insurance company is having record profits in between. I think there has to be a smaller share of that dollar for the middlemen, a larger share for the people actually doing the work of taking care of the patients.
Yeah, absolutely. I mean, as a primary care doctor, you're speaking my language.
The same would be true of surgeons
Sure.
or renal specialists or MSK doctors. The point is the same. The essence, when people say we have a bad healthcare system in the United States, I strongly disagree with that. I think we have a terrific healing system in the United States that does surgeries and invents drugs and medical devices and counsels patients who are in deep trouble. I think it's the best system in the world. But the regulatory and economic infrastructure that supports that system is all fouled up. That's the problem.
Sure.
So the problem is not that OBs are doing a bad job advising pregnant women. The evidence is they're doing a really good job when the woman sees them and they're given the right tools to do the work with. The problem is not that people do lousy spinal fusions in the country. Most people do really good ones. There may be too many of them, but they do really good ones. The problem is the 30 to 35 cents out of every dollar that is taken for people who don't do anything for the patient, but just process the money, who take the money from the payer and take a big chunk of it out before it gets to the provider. So if I had one wish for the system, it would be that 30 to 35 cents becomes 10 cents, 12, and the excess would go to providers to compensate them for the great work they do and for lower costs for the people paying the bill.
Sure. How, along that same line, you mentioned capitation and that kind of system is one way that the HTA coalition is kind of working to
Right.
improve quality and value. What are some other ways that this coalition is working towards that objective of higher?
Second opinion on surgery. And we don't do it, by the way, but we work with qualified clinicians, and many of our employers will say, okay, the doctor says you need a spinal fusion. Um, we want a second look at this. We want a second look at it. Now, employers do different things. Some would say if the second opinion is no, then the answer is no. Others would say if the second opinion is no, then the cost share is going to go up if the patient has surgery. In other words, if the second opinion is yes, the cost share might be $500. If the second opinion is no, but the patient has surgery, it might be $2,000. And then other employers won't differentiate based on cost share, but they at least want the patient to think about it before they make that decision. The evidence that I've seen suggests that maybe 15% of spinal fusions could be treated with diet, exercise, weight reduction, physical therapy, and don't really require surgery. I never want to make that decision. I'm not competent. But we do have programs where competent people do take another look at that. In the cancer area, we try to work with partners who are really good at encouraging people to get early screening. And, I'm talking to people who know far more about this than I do on this call. But what I know as a layperson is that the earlier that a cancer is detected, the higher the likelihood you will have a successful outcome. The later it is detected, the less likely for a great outcome and the more expensive things become. So, we're looking at encouraging employers to have easy access to breast cancer screening and pap smears and colon cancer screenings and prostate cancer screenings and skin cancer screenings and all these kind of other things. One of our member companies did all these things. And here's what happened. The average in our database, in our marketplace, is that when someone gets a cancer diagnosis, 42% of the time they have full remission. This is talk about all cancers now. Obviously, it's skewed by type of cancer. This company that aggressively did earlier screening has a 64% full remission rate. You might say, well, they must have spent a fortune on that. Their spend on cancer is exactly in the middle of the market. They spend more than half of their peers and less than half of their peers. That's what can happen. And that's what we mean by value-based care.
Yeah. And I mean, as a majority of Americans get their health insurance through their employers, I think working with
160 million Americans.
Okay, yeah. Working with the employers is a powerful way to really shift that conversation towards more value.
The other reason it's powerful, and I have seen both sides of this, that I've been with the HTA for all 11 years that we've been in existence, and I've had the honor of serving in the Congress for 24 years. So I've seen both the market and the government. If we wait for the government to make a significant dent in cancer, we're going to be waiting for a very long time. It's just slow the way it moves. You can move faster with employers. The company that I mentioned, a big financial services company, accomplished this over about a 2-year period. And they did it. They didn't have to pass a law or start some new thing. They did it with their checkbook. They basically said to their carrier, you're not really doing much about this. So we're going to take some of the money away from you, and we're going to hire a company that's really good at educating and encouraging early screenings. We're going to pay more for early screenings. Not surprisingly, their radiology bill went up, but their total bill went down. And what's more important, cancer care isn't about what did you spend on it, it's what happened to the person. And there's a lot of people alive today or living well today or better today because they had earlier screening. And they also played a very active role in formulary management for chemotherapy, where what I know about chemotherapy is this much, but I know enough to know that all cancers are not the same. All chemotherapy treatments are not the same. And it's a very skilled process to match the cancer, to get the cancer diagnosis correct and match the correct diagnosis with the right chemo to get you the kind of result that you want. So value-based care can happen when buyers demand it. And the HTA is really about demanding it. It's about taking as much of that $45 billion a year that our members spend and saying, we're not just going to send the insurance companies money and say, oh, well, women of color are more likely to have preterm births, which is true. We want to do something about that problem. We want to identify the people who are, whether all among all women, we want to identify the women most at risk of preterm birth when it's early enough to intervene in a successful way, and hopefully try to manage that pregnancy in a way the baby goes full term and goes home instead of the NICU, and the mom goes home instead of the ICU. That's not just an economic proposition, that's a life-changing proposition for a lot of families.
Sure. On that subject, are there specific ways that the HTA is working to address those kind of health equity concerns?
We are. One thing that we do is we have a data platform that has 5.3 million lives in it, people in it. And that's a big enough platform that we have a sufficient number of Latinas and African American women and Native American women and Asian American women. And it gives us the ability to ask questions like, is there a racial identity to preterm birth? The answer is yes, there is. Now, once you know that, the way you can take action on this, we did this with the Meharry Medical College in Tennessee, which is a primarily African American faculty and student school. They have a terrific program of early intervention with pregnant moms that helps to avoid preterm birth. And so we made our members aware of that. How can you target, and it would, again, not just minority women, how can you target women generally who are at risk of preterm birth? And then what can you do to help alleviate that problem? And the answer is not rocket science. It's frequent check-ins by a nurse. The OB visits being, maybe once a month instead of once every 2 months early on. Nutrition counseling and social support for that. Finding out about the mom's history. One of the quotes I just read this week, I think it was Osler, one of the great minds in medicine, said, I'd rather know more about the person with the disease than the disease the person has. I want to know more about the person with the disease than the disease the person has. In other words, what's this person's life like? And if you find out that a pregnant mom has 3 other children and they're all under 6, and she's responsible for getting them to school or childcare or whatever every day, it would suggest that maybe you schedule her appointments at a time that's viable for her and not first thing in the morning. Maybe you find a way through telehealth that she can do some of the appointments virtually. If you're her employer, maybe you give her PTO for the appointment without docking her pay. There's a lot of very practical things here that are not science fiction remedies, they're common sense. And what we try to do is take the data that we have, take the resources that our employers, things like giving PTO, and do that, use them.
Yeah, I mean, to that point, I think one of the benefits of this type of model is that employers can be more flexible and innovative to address those barriers to health for their patients, which of course they want to keep their patients healthy and their employees healthy, but also it just saves money. And so
Exactly.
that
Exactly.
alignment.
And it's important to understand here that there's both a moral and a commercial argument for what I just said.
Hmm.
The moral argument is, yeah, most employers really do care about the people who work for them and they want what's right for them. That's not always true. And it's not always enough. When you add to that, that a healthy person is a lot easier, less expensive to take care of than a sick person.
Hmm.
A baby who goes home on day 2 instead of the NICU for 2 months is a lot less expensive to take care of than the baby in the NICU. So there's that. There's that aspect of it. So the employer is paying the bill. The second, though, is the cost of recruiting and retaining employees. The number one job of most HR leaders in companies is to find and keep great people to keep them working there. If you see your health benefits as a hassle, as not being there for you when you really needed them, you might go to look work somewhere else. You know, right? And you may tell your friends, yeah, I work here because I have to, but I wish I weren't.
Sure.
On the other hand, you want someone saying, thank God I worked at employer X because when I got the terrible news that I had a cancer diagnosis, they took really good care of me. When I found out that my son is autistic, they took really good care of him. You know, when I found out that when I, broke my knee playing soccer last weekend and they got me really good care right away. So employers have both and the economics behind that, by the way, it costs twice as much to replace someone as it does to keep them. So if you're American Express, one of our members, and you got a woman who's an underwriter in your loan department, and she hates her health benefits and leaves, and she's making $120,000 a year, it costs you $240,000 a year to either pay other people to temporarily do her job or pay people overtime if that's what you have to do, or do the recruiting and replacement and retraining of somebody to take her place. It's a lot cheaper to keep her. And one of the ways to keep her is if she feels like when she needs that health benefit, which for most people isn't that often. Happily, most people, most time are not sick. But when something does happen, a car accident, a problem pregnancy, really any pregnancy, God forbid, a cancer diagnosis, a renal failure, a mental health issue, depression, anxiety, schizophrenia. If that employee feels like my company was there for me when I needed them, they're a lot more likely to stay. And so there's an economic value to that as well as a moral value.
Yeah, absolutely. And on that, a similar front, I think now what often patients and physicians don't realize is that employers can choose what is covered under their benefit plan. And in that same vein, like some, I find patients, some of them being really excited that their company insurance covers XYZ new trendy thing, and other patients are upset that it doesn't cover XYZ new trendy thing. A big example of that right now, of course, is the GLP-1s. And then
Absolutely.
another kind of emerging area is like cell and gene therapies and things like that. And so, what factors go into that decision making when employers are deciding what to cover and what not to cover?
It's a brilliant question. Every employer is different, but generally speaking, here's how I could describe the market to you. So imagine an XY axis where the X axis is the profitability of the company. The low end, it's got a very thin margin. At the right end, it's got a very high margin. And the Y axis, the top of it, the Y axis is the degree of skilled labor in the labor force that they have to hire. So the top of it would be highly trained people. The bottom would be relatively less trained people. So think about a retail store in the bottom left quadrant. Very thin margins, and many of the people who work there are not highly skilled in a formal education sense. And then think of a software company in the upper right part of the quadrant, Meta, or Amazon's really a software company in many ways. In the upper right, very big margins, fat margins, and they're hiring electrical engineers and PhDs and high skilled workers. Generally speaking, in the upper right quadrant, the employer will cover just about everything because to compete for an electrical engineer or an MBA who specializes in forensic accounting, that's what he or she wants. And the way to protect your margin is to have great people. And the way to have great people is give them what they want. So fertility benefits, GLP-1s for weight loss, not just for diabetes management, respite care, lots of other things like that. The bottom left quadrant, the supermarket operating on a very super thin margin. Again, supermarket employees are really skilled people. I couldn't slice meat or I couldn't do any of that, but they don't have a PhD or a master's degree. And, in some ways they're looked at as also maybe more replaceable by AI more quickly. Like when I used to go to the grocery store, it was the oddball that used the self checkout, and normal people like me waited in line for 45 minutes. Almost everybody uses the self checkout now. So there are fewer checkout people. So that's a description of the way employers think about this. I don't know any employer who likes that, who would want to say to their supermarket employee, well, we know that your next door neighbor is on a GLP-1 and she feels great about it and you'd like one too, but it is $600 a month net of rebates. And the evidence, by the way, shows for this that you get about $1,800 a year on reduced medical costs for a GLP-1 recipient for a $7,000 a year RX spend. Okay, that's what the numbers look like now. And so the short answer is if the employer's in a very competitive labor market and the margins are pretty broad, yeah, they'll cover all kinds of things. And that's the person who's in your office who says, oh, my company covers, extensive dental care or whatever. If the person is working in a call center for a credit collection agency, yeah, probably not. And I don't like that. By the way, the way to fix it and what we've done in the Affordable Care Act, there is a basic benefit package that everybody has to cover. So you can't say we have a health insurance policy, but it doesn't cover surgery. Or we have a health insurance policy, but it doesn't cover prescriptions. I mean, you can't do that. At some point, I think the basic benefits plan is going to start to cover more of these things. Like gene therapy. This is coming. I read earlier this week, you may have as well, there was some very promising news about gene therapy for LDL levels for cholesterol patients. Really promising news that some kind of gene editing might dramatically and permanently reduce LDL. I have an issue with LDL, genetic problem with LDL. There's 20% of the US population probably does. I don't know that these gene therapies will all be $2 million the way they are now, but they're not going to be $300 either. Mm-hmm. So that's a massive problem that is coming our way. And if I had to predict, I think the system will divide in two, and there will be a fully insured product for really high cost claimants like gene therapy recipients, where employers will pay a premium, a risk-bearing entity will manage that cost, and then self-insurance for normal pregnancies, sprained ankles, rashes, the things that people have normally that are not high-cost situations. But that's coming.
Sure. Okay. Well, the time has flown by. We're about heading into our section for our time for asking questions.
Yeah.
So let me go ahead and start asking some of the audience questions. And as a reminder to the audience, please enter your questions in the Q&A and I'll start reading through them. Um, so this question is from Janet. She says, thank you for what you did to change some of the worst problems in access to healthcare. I
Thank
do
you, Jim.
wonder how we would really develop metrics that can assess the quality of care. MIPS
Yeah.
was one way the Obama administration tried, um, and it just felt like checking a zillion boxes. So, how do we develop the right metrics and incentivize doctors the right way? And I'll add my own section to that in a way that doesn't feel so click or onerous.
Bureaucratic.
Yes.
Yeah. I think the key to that is the word we in the question. How do we come up with metrics? The we should not be me. The we should be the men and women on this call. That you won't have unanimity, but I think you would have consensus let's say we said the question, let's define what excellent pre-diabetes management looks like. Let's define that. Now, I'm not competent to answer that question, but primary care doctors, endocrinologists, I think the others are. And, what pops to my mind would be some look at progress or lack thereof on A1C reading. Some look at progress or lack thereof on blood sugar levels. There are measurable things. Again, risk adjusted. Risk adjusted. You got to take into account what the patient came in on the way in. But I would be very comfortable with a system where we find the consensus point among qualified, competent clinical practitioners, and they write the definition, not bureaucrats and politicians and business people. Now, I know that it's easier said than done. I got that, but I do think it's possible to define meaningful qualitative and quantitative standards that don't require 300 boxes that have to be checked. Um, that's what I think we ought to do. I
Yeah,
mean, if you took someone's waist circumference twice a year, it tells you a lot about weight management, doesn't it? I mean, it's a pretty simple stat. Now, I know that there's a lot of things that go into that. Some of it's genetic, some of it's behavioral, some of it can be changed, some of it can't. There might be some treatments that would work on someone that they're not strong enough to bear or ineligible clinically for some reason. I think you can take those exceptions and screen them out, but I'm confident enough that smart, competent people could come up with meaningful standards.
yeah. Thank you for answering that. And then in hearing you talk about it, I think this conversation is coming at an interesting time with kind of the boom of AI and thinking about how can we utilize that in healthcare. There's, in my mind, that's one way that could make it easier for us is just kind of
As long as, and I agree with that, I think the proper use of AI, it reminds me of it actually reminds me very much of robot assisted surgery. My mother in law, God rest her soul, died 2 years ago. She had a TAVR, transarterial valve replacement, when she was like 82. And they put a pig's valve in her heart. I of course never said to my mother-in-law, you have a pig in your, I never said that to her. But at any rate, the surgery was actually done. A physician, cardiologist sat behind in a booth and oversaw the surgery, and it was done largely by a robotic situation. I think that's fine. And that's the analogy I think we should use with AI.
sure.
That there is work that can be done and should be done on development of standards as long as it's overseen by ethical, smart, competent humans who impose judgment on top of that rote. I wouldn't really go to ask Dr. Grok, I have a pain in my side. What do you think I ought to do? I ask him, but I'm not going to stop with that. I'm going to go talk to a competent human to tell me give me advice what to do.
Yeah, absolutely. Okay, this next question is from Scott. Setting aside the enormous political difficulties involved, what is your view on a single payer solution, either federal, such as a Medicare for all, or a state-based system as a policy solution
Yeah, I
for,
don't favor Medicare for all, state or federal. And here are my concerns. The first has to do with investment. The second has to do with corruption. So here's the investment one. Um, Basically, single payer means that the government fixes the price of every medical procedure because the government determines what it's willing to pay. Um, there have been, well, let's use the example of preterm births. There are children born now at 27, 28 weeks, 2 pounds, a pound and a half, who survive and thrive. And by the time they're fine, by the time they're a little bit older. The things that helped make that happen were some incredibly expensive medical devices, some incredibly expensive medicines, some incredibly complicated monitoring systems and data gathering systems. And the people who invented those systems made a boatload of money by inventing them and selling them. I'm glad they did. because they save the lives of those children. Um, how, if the government set that price and it didn't really reflect the value of that care, what you will do is dry up investment in that creativity. Because remember, investors aren't deciding which medical device to invest in. They're deciding between medical devices and gambling casinos, or medical devices and data centers, or medical devices and cruise ship lines. That there's all these other possibilities out there for them to make money on. So if you have an artificially limited ceiling on price, I don't think you get the invention of devices, medicines, techniques that are truly revolutionary and breakthrough. That's problem number one. Problem number two is corruption. And I don't necessarily mean kickbacks and payoffs, but um, if the government runs everything, then the way you get to change something is to have a politician take your side and try to change it. So imagine that you're at a health system and you're doing a really good job on elder care, and you're helping a lot of seniors who are pre-kidney, pre-renal failure, manage their diet and better, keep them off of dialysis as long as you can, maybe forever, minimizing the need for transplants. And you're doing a really good job of it. And then the hospital down the street who's not so good, puts the wife of the local congressman on their board and pays her a big salary. The way American politics works is that inevitably there's going to be some pressure on more dollars to flow down the street to the hospital that's not doing a better job. Now, there's some of that today already. I'm not saying there's not, but I just worry about the fact that opportunities would be given out based on favoritism and political connections and not necessarily on the basis of what's right. Is our system today, does it have those problems that I just mentioned? Yes, it does. There's some ridiculous waste of money in our system. But there is creativity that I wouldn't want to squeeze out of it. And then secondly, if you don't like what the hospital down the street is doing, outcompete them, do a better job. But if the government is your only customer, see, that's the difference. That you might say, well, the customers will vote with their feet, the consumers will, and they'll go to the right hospital. I don't know about that because there's so many regulatory levers that can be pulled and so many disadvantages that can be put against a disfavored hospital. So I don't like it for that reason. I'm certainly in favor of everyone having coverage. That's why we did the Affordable Care Act. But I think having everyone in the Medicare system with no other alternative would be a mistake.
Well, thank you for that perspective. Our next question shifts gears a little bit. It's from Jeffrey, who said a great presentation. And then
Thanks.
he asked,
And thanks, Scott, for your question. I'm sorry. Yeah.
what is the attitude of the businesses you work with towards the large health insurance companies and PBMs?
It's a love-hate relationship. It's a very complicated relationship. On the positive side, the big PBMs and carriers, and they're really the same thing. You realize that Optum Rx is owned by United Healthcare. CVS is owned by Aetna, or CVS owns Aetna, actually. What used to be called Express Scripts is now called Evernorth, is owned by Cigna. So they're really, there aren't PBMs and carriers, there's carriers. Employers like the fact that they are very good at assembling networks so that if one of your employees is on vacation in Disney World, you can get care for them and they get plugged into, it's out of network care, but there's a way to get care for them. They like the fact that they handle billions of claims a year. And although they screw up some of them, most of them get paid and the employers themselves don't have to worry about that tremendously time-consuming function. They like the fact, depending upon the degree of customer service they do, that when there is a real problem, that somebody needs a heart transplant and there's bureaucracy to be cut through, some of the carriers will be faster than others in solving that problem. What they don't like ultimately is that they feel like the middlemen take too much of the dollar and not enough of it goes to actually provide care. Problem I talked about earlier in the hour. There are alternatives to big PBMs and carriers, and about 10 to 15% of employers are using those alternatives. There are what are called third party administrators who aren't carriers, meaning they don't have a Medicare Advantage or fully insured business. And they tend to operate much less expensively than the big carriers do. There are pharmacy benefit managers that don't take income from drug companies. They only take income from employers. And I think the value of that is it's really hard to imagine a situation where a fair negotiator is taking money from both the buyer and the seller of a product at the same time. Really. I mean, what else works like that? So employers, I won't say love, appreciate the fact that the enormous economic engine behind all this money changing hands is something they really don't have to worry about. Someone does it for them. But they don't like the fact that someone, I think, is taking too much of that dollar and controlling too much of what happens with the outcome. So none of our members are, burn the house down and get rid of all of them. But I think some of them are. But most of them are, I wish they would perform better. And what we think the answer to that is, for those who want to stay with a big carrier, well, let's make their contract depend in part on outcome. Say to them that the financial services company that I mentioned earlier had this great success with cancer. Why can't you do that for us? Why can't you take responsibility for increasing the number of early screenings? Why can't you take responsibility for better identification of women at risk for preterm birth and intervene successfully? And part of what we pay you is going to be based on whether you do that well or not.
Yeah, that's a very interesting relationship, kind of a love,
It's
love.
a complicated relationship. Yeah, it's they used to say in Congress that people hated Congress but loved their congressman. Like the idea of Congress was, all these crooks. But Congressman Smith back home, we love him. It's not so much anymore. I mean, there's that sort of hatred, but it's a very strange oxymoronic feeling.
Sure.
You know,
Um,
I hate big hospitals, but I love Dr. Patel. You've
sure.
heard that, right? Yeah, the hospital's a mess. It's bureaucratic. The parking was awful. The cafeteria food was awful. They kept sending me bills that I didn't have to pay. They ran all these people in and out. It was chaos. I just sit there all day and wait to hear what was going to happen to my mom. But Dr. Patel was awesome. It's part of that feeling, right?
Sure. Yeah. All right. I think we have time for one last quick question from Eric. How has the HTA been impacted by HR1? And on the other hand, what are some ways that the HTA is fighting back on some of the negative consequences of it?
HTA employers are paying more because of HR1. When uninsured people show up at the emergency room, they get care. No one pays for it. The hospital, at first, the first thing the hospital tries to do is shift the cost to people who do pay. Can't shift it onto Medicare because they fix the rates. Can't shift it onto Medicaid because the rates are so low, you can't, there's no money there. So it's shifted onto commercial payers. So we're paying more because of HR1. What we're trying to do about it is, I mean, it's not so much HR1, but we're trying to keep people healthier in the first place. So that if it's pretty hard to beat the reality that the spinal fusion is going to be more expensive because of HR1. Because well, that's a bad example, actually. That the ER visit is going to be more expensive because of HR1. Well, okay, maybe we should try to find a way that fewer people go to the ER, the emergency room for care. That let's make primary care more readily available and more convenient for people. So if they don't, for instance, many of our employers are now having someone who can do 24/7 virtual primary care. I woke up in the middle of the night. I've got this really bad stomach ache. I think it's okay, but what should I do? Should I go to the ER or not? Our employers, by the way, want that person to do what they think is right. It's not like, no, don't go to the ER, but give them the option, getting a doctor on the 3 a.m. and she'll say, well, tell me a little bit about what's going on here. And she will render judgment that says, yeah, I think you need to go to the emergency room. Or why don't you try this and let in 2 hours, let's get back on the screen again and see what's going on. That's what they're trying to do. So keep people out of the environment where the cost shifting is taking place. Politically, and we're not a political organization, but my own view is we ought to restore the subsidies to the exchange marketplace people and get them covered again. Right? Somebody's going to pay for this. The idea that saved money is false. All it did was to shift the cost of taking care of those individuals to hospital systems and employers, commercial payers. That's what it did.
Yeah, those are really helpful insights, and I think we can all kind of feel the realities of that slowly starting to come into effect in our day-to-day practice. So I think that's about all the time that we have. So I would like to close our session by thanking Rob for such a thought-provoking discussion, and we're so grateful that you were able to join
Well,
us.
I'm grateful, as we said before we got on the air, that I'm prejudiced. My daughter is an internal medicine doc here in Arizona, and when I'm finished this, I'm going to walk out, and she's going to be doing pajama time. I'm sure of it. And I've learned through her life what you all do, and I appreciate even more what you all do because of her experience. So
Oh,
thank you.
no, yeah, thank you for those kind words. I'd like to thank everyone in the audience for being here and for all you do on behalf of patients. We hope that you'll become an official DFA member today if you are not already. The number one reason doctors, medical students, and health advocates join DFA is to be with like-minded people that share the same values and priorities. Please watch for additional opportunities to engage with DFA, including our National Leadership Conference, June 5th through 8th in Washington, D.C., and we'll be sending a registration link in the chat. I'll be going. It's my first time going. I've heard wonderful things, and I've been to the Hill on this kind of advocacy visit before, and it's really energizing. So if you're on the fence, definitely.
Please go. It makes a difference. Haven't been on the other side of the desk. Please go.
Yeah, it can feel really empowering. So that's my own personal plug for it. For those of you who are sustaining members of DFA, just a reminder to please complete the survey in the chat for 1 credit of CME for attending this session. And finally, if you enjoyed these advocacy grand round session, please consider supporting DFA's work and impact with a financial gift. And the link for that donation will also be put in the chat and is available on our website. And then you can follow us on Twitter, LinkedIn, Instagram, Blue Sky, and Facebook to stay up to date with all of our programs, events, and ways to get engaged. Thank you all so much for attending. Thank you, Rob, for this really fascinating conversation, and can't wait till next time.